Hey, welcome everyone. My name is Andrew Weeks. I'm the president of the Liverpool Medical Institution for this year. So we're running this program, as most of you will know, about bringing life, all about birth and about, especially related to the national debate going on around birth. What is birth? Why are the massive fluctuations going on in care around the country? What are all the inquiries about? How can we improve care? There's a big cultural change going on. And so we're running this series, and you'll see on the LMI website the series of 22 lectures that we've got. So as we start 2026, we're delighted to have our first speaker, Susie Crowe. Now, Susie is a consultant obstetrician down in London, and I'm grateful that you've come up all the way today from Bart's NHS Trust, where she's a consultant there. But I guess more for your important, for the role that you've got nationally, is as NHS England National Specialty Advisor in obstetrics, which means she's really at the very centre of trying to work out how we move on from here and how we get the right balance between intervention, natural childbirth. How do we, as a country, respond to the changes that are going on? She's also the RCOG National Workplace Behaviour Advisor, which is specifically relevant for this topic, because she talks a lot about one of your passions, I think, is compassionate care in labour. And how do we enable that? How do we facilitate that? How do we make it a reality? And what is the effect that it has? I know Susie particularly as president of the British Intrapartum Care Society, BICS. And BICS is a fantastic institution which I joined a few years ago, a fantastic society. And we meet every year for an annual conference at which we discuss all these topics. And it includes both obstetricians, midwives, and patient representatives and campaigners. And we all meet together as a way of trying to bring together and get that joint care right. So without any further waffle from me, I'm going to hand over to Susie to talk to us about compassionate maternity care. The people online, thank you very much for joining. If you put any questions in the chat, then we'll pick it up at the end. Those who are here in the room will have first chance for questions, and then after that, we'll move online so that everyone gets a chance to speak, and we'll be finished by just about 7 o'clock. So over to you, Susie. Thank you.
Thank you so much. Thanks, Andrew. So thank you for inviting me up here. It's really lovely to be here. I always really enjoy getting around the country and meeting different people, and also being able to engage in this. I think one of the most important things that we can do is really listen to people and listen to how we're describing birth at the moment in the UK, what people really want, and how we can really make things better. And I spend a lot of my time trying to do that and try to work out what to do. I'm going to start by kind of going back a little bit to, I suppose, me and where I've come from with this. So whenever I go around to people who don't know anything about obs and gynae or maternity, and I tell them I'm an obstetrician, most people say to me, is it like this is going to hurt? Is that what it's really like? Now, really interestingly, when Adam Kay first worked at Chelsea and Westminster, I was his SHO. So actually what he described was somewhat sensationalized, but actually was very much my life at the time. Many of the people he interviewed for those sensationalist stories are my friends. And that kind of harshness, I think, that was around at the time was very much prevalent in the early noughties, was what it was like. I certainly remember being told by somebody that I was too nice to be an obstetrician, that I didn't have a nasty side and I needed to develop it, and particularly if I wanted to be a woman obstetrician, because you had to do that to be better than men. And even now, this study that you can see there came out even this year, talking about how kind of the impact of women on women bullying in medicine. And I sat there and thought, I don't want to be like this. This is not who I am. This is not what I want to do. I want to do something differently. I, a bit like actually what happened in This Is Going to Hurt, had an awful case with a baby that died when I was a very junior registrar. The baby died after I'd left my shift, but there was a significant blame culture at the time. We're talking kind of early mid-noughties. And I almost left Obs and Gynae at the time because I thought I don't want to be part of this. But then I thought actually the only way to make this better is to be in there and to make it better and to lean in and try and make it better. And I suppose that's how I've forged my career in intrapartum obstetrics, being that person trying to make a difference and make things better. And then just a little bit, say, a personal story. And again, I think one of the things that we don't talk often enough about as doctors, who are also patients, who are also mothers or fathers, or who experience care, is that actually we are all those people. We are human beings who often experience the care of the NHS or in maternity care ourselves. And actually that those things can change us and should change us. And how they change us and how they impact on us and whether they impact on us and change us as doctors. So this is my eldest son here. He doesn't look like that anymore. This is 16 years ago. He's now 6'2" and about to do his GCSEs. And I was just saying to Andrew, he's considering doing medicine. I was kind of wandering around Liverpool this evening thinking, oh, I wonder if he'll consider Liverpool. So you never know. But this was when he was just born. So I had severe preeclampsia. I had him at 35 weeks. You can see he's got a slightly yellow tinge because he had quite bad jaundice. But it was absolutely fascinating being at that point on the other side of maternity care. And what I suddenly realised as an obstetrician is the impact of kindness, of compassion, and on when you're feeling so vulnerable. And I think that's what we don't really describe well enough about pregnant women and what it's like to be pregnant, is that vulnerability you feel about that kind of wanting to protect your baby, that's so different to if and the level of trust that you need. If you don't trust the orthodontist who's going to take your wisdom tooth out, it's not the end of the world, really, is it? It might not be the best experience. But actually, if you don't trust the people who are there to save yours and your baby's life, I think it can be really very, very damaging. And I had some absolutely amazing care. I also had some care that was really quite shocking. People who told I chose to have an induction of labour because that's what I felt that was the right thing for me. And I had an obstetrician telling me I was completely mad and that he didn't know what I was doing and what was I hoping to achieve. And I mean, thankfully for me, I am an obstetrician and I felt empowered to make the right decisions for me and to have that personalised care. And it made me realise the impact of that personalised care. But I also felt very, very ill with that preeclampsia as well. And the impact of the midwifery care that I had that was so kind and just the little things about personal touch, the way that somebody gently puts a blood pressure cuff onto you, the way that somebody just gently strokes your hand and makes you feel as though you're being nurtured and secure, made all the difference. And it suddenly made me realise what good midwifery care really is, which we don't really necessarily see as obstetricians. So it definitely changed me, and it definitely made me want to champion women having personalised care and having the right thing for them, because we all are agencies of our own bodies and we all know what the right thing is for us and for our babies, and being listened to is the most important thing. So anyway, that's back then. Where are we now? Andrew, I've stolen your slide. This is where we are now in maternity care. So I'm describing what happened when I had my first baby. I had 2 more babies after that, by the way. But then that was 16 years ago. We're still talking quite a lot actually about what happened 16 years ago, which I think is part of our problem at the moment. But we are in the midst of a maelstrom at the moment in maternity care in the UK. It's not actually just the UK, it's actually going all over the world. If you look at the Australian press, there's a lot of debate over how women birth. If you look at the American press, there's a lot of debate over how women birth. So a few months ago, in one weekend, there was an article in the Sunday Times in the UK talking about the curriculum for midwives and how they're being trained in physiological birth, and essentially trying to equate physiological birth with unsafe birth, which we know that the statistics don't bear that fact, that Scandinavian countries have very high rates of physiological birth and very good rates of safety outcomes as well. So that correlation that we've got in the UK and in our mindset is just not right. At the same time, in the United States, the rates of caesarean birth have gone through the roof, but actually their outcomes are still not great, particularly if you look at maternal mortality. And so the American press seems to be getting very hot on the fact that American obstetricians are over intervening, and they're talking a lot about the impact of caesarean birth and a placental accreta spectrum, poor outcomes associated with that birth. And then similarly in Australia, that same weekend, there'd been a poor outcome with a woman who was birthing at home being supported by a doula. And there was also that toxic debate that then started in Australia around home birth as well. So you can see that maternity care and how women birth is a societal construct. And I think we are at the minute caught to a certain extent within the middle of that, and particularly with how social media works, with social media outcome, algorithms work, and that we are in the middle of this toxic debate that I think is very much being driven by social media, by media, and doesn't really get into the heart of actually what's really happening on the day-to-day on the shop floor. But this is where we are, isn't it? So we have had review after review after review in maternity care. So even in the times in which I've been a consultant obstetrician, we have had the Morecambe Bay inquiry, so the Kirkup inquiry into Morecambe Bay. We had the Better Births report. We've had another Kirkup inquiry into East Kent. We've had the Ockenden review into Nottingham. We've had parliamentary inquiries. We have got the ongoing reviews, which have just started, this is the AMOS review. And we've had so many things coming around and about. And what we see is these headlines, don't we? So we see these headlines: hungry mothers, dirty wards, maternity care much worse than anticipated. One of the things I would say is that we have this huge lens on maternity care, and I'm not saying that this is right or wrong or that these things aren't true. And, they've interviewed a lot of staff as well. But what I would also say is that we need to consider it in the context of the whole NHS. And I work as a gynecologist as well. And I can assure you that things are not sweeter in other specialties necessarily either. But this is where we are. But each time one of these things comes out, we feel the morale dipping down that bit further in our staff. And so the question is, what is really going on? Are we getting it wrong? If we are getting it wrong, how do we get it right? And so, but why is it that I think the maternity is really up at the front of it? So firstly, maternity care affects most people, doesn't it? Unlike cancer care or cardiology or any of the other things, your family, well, 50% of people get cancer in their lifetimes, but, your family may experience care in those other bits of the health service. But actually, the majority of families have somebody that gives birth. So the majority of people will have that insight into the hospital. It's often people's first exposure to healthcare. Women are young and fit and healthy. Often they're not seeing doctors in any other situation. And so this is their first interface to that healthcare. But I think the other thing, and that's what I alluded to at the beginning, is actually why it is that we need to get this right is because our behaviours matter so much, and they matter so much more potentially than other parts of healthcare. So how we make people feel can have such a massive impact. So we know that we've seen all these things around birth trauma. Again, another one of the inquiries or reports. We had an APPG into birth trauma. This is Theo Clark, the former MP, who had a von Toos birth and a hemorrhage. And again, she describes feeling very scared for her life, scared for the life of her child. And we know that actually those things can be then very traumatic. And actually, even the concept of trauma is something that's only 20 years old. So you can see how it is we're only starting to talk about this. Trauma as a concept came from the Vietnam War. We only started to talk about it in psychological circles 20 years ago. I think our younger people around us we're talking a lot more about trauma, but it's quite a new concept. And it's one of the reasons I think that we need to recognise that and be addressing it. I don't think birth trauma is a new thing. It's just something that we weren't talking about or addressing previously. But we also know, and I know, and I'm sure Andrew knows as an obstetrician for years of working with women and families, that there are some women that I've looked after, or, and certainly when I used to lead services, I used to review all the complaints. There were women who would come describing their traumatic experience, but actually their traumatic experience might have not been listened to on the postnatal ward, that was busy and not enough time to listen to them. But they might describe what would other people might have described as a traumatic birth, a forceps in theatre, losing lots of blood. But they would come and say, actually, it was fine. It was okay. I felt okay because people explained things to me. I never felt as though mine or my baby's life was in danger. So there's still something, I think, within our professions that we're not quite distilling enough in this and quite focusing on enough. We have a huge amount of focus on our technical skills, but are we still really focusing on our non-technical skills as well? Because what we're describing is actually over the course of this time, we're describing a system that is apparently failing. And isn't working. But we're also describing a system that has changed dramatically over the last 10 years. It's quite unrecognisable, actually, maternity care compared to 10 years ago. We're not describing the fact that we actually do save the thousands of lives every year and that maternity care is actually getting safer, that our rates of stillbirth, neonatal death and term brain injury are reducing, and that we are actually surrounded by people who do amazing things every day with kindness. And I can point to some of the staff I work with day in, day out on our labour wards who do those things. So both of these things can be true at the same time, can't they? These things can be true, but it can also be true that lots of women are getting birth trauma, that our wards aren't serving women right, and that we're still not getting something quite right. And the question is, what's that gap and what's missing in between? Okay, so one of the things that we need to look at and have a kind of bigger picture of is how we've ended up where we are now. So maternity care in the UK is now one of the most policy-heavy areas of healthcare. There is no other area of healthcare that we have in the UK at the moment that has as many policies. There was something that went on I think it was the BICS Google group recently, wasn't there? We've got the British Intrapartum Care Society has a group of members, and we have this Google group where people ask questions. And somebody recently asked the question about how many guidelines we have, each unit has. So as human beings, obviously guidelines are good. We all want to practice evidence-based medicine, whatever specialty we do. We need guidelines. We need guidelines to help to inform us. Guidelines first came in, 25 years ago. The first one was a hemorrhage guideline. If you go back, it started when we first started doing confidential inquiries into maternal deaths. And one of the first guidelines that came out was the postpartum hemorrhage guideline. We recognised that there were improvements that could be made. And so over the course of the last 15 to 20 years, the RCOG has produced guidelines, NICE produces guidelines. We also have policy. So I work in NHS England, I work on policy. That's also guideline-ish to an extent. And that means that each trust therefore has a set of guidelines. So as human beings and as doctors, we try to work to guidelines, but there's only so many guidelines any of us could ever, I suppose, read or conceptualize. So the average number of guidelines that came back that people were saying that each department had was around 130 to 150, which is a staggering amount of guidelines. And so what we have is a system where we're saying we're making it better, we're putting all these guidelines in. Why aren't people following guidelines? But we're not following guidelines because there are so many of them. And do they necessarily fit into providing personalised, individualised care? Are we actually getting this right? Are we making it better by having so many guidelines? That's not to say I don't believe in guidelines. We need them. But the question is, are we making it safer by having so many? And then the other question is, how evidence-based are they all? Are they actually evidence-based guidelines? And so again, thinking about compassion in this system, if we're constantly reviewing cases and saying, why has something happened? And then the question is, well, it's because somebody didn't follow a guideline. Is that really how a human system works? Is that really understanding and being compassionate towards our staff and the person in front of us as well? And actually, just today, there's a study that's been published that I've seen that's been published recently in an American journal, analysing the evidence base behind the RCOG Green Top guidelines and the high quality evidences between 40 and 50%, and a significant amount of them are on expert opinion. Now, this is actually quite widely shared in public terms. If you look on online and at women who are seeking information from other places, what you'll often find is other healthcare professionals or birth workers or people in this space saying to women, you're allowed to challenge what doctors are saying. You can challenge what doctors are saying because actually the evidence base upon which they're giving you their advice isn't necessarily as strong as you might like it. And we need to be aware of that as well. So that's the first thing. Then the second thing is then how do we prioritize? We've put a whole load of things into the system. We've piled things up and up and up. And again, recognizing we're already human beings working in complex systems. So working on a labour ward, delivering intrapartum care is really complex. We're juggling lots of things at the same time. It's really noisy. It's actually quite, it's the kind of place where actually you have to be able to kind of tolerate quite noisy environments. It's bright, it's loud. It's quite distracting. It often doesn't have any natural light in it. And again, we need to recognise that. We need to understand human factor science and try and make it simple so that we actually have the space to think and the space to do the right thing. So, and then how are we then making sure that we are doing the right thing? Are we measuring the right thing? We have a constant debate, certainly in my world, about data and what data counts, what data should we be measuring, what actually are the indicators of safe maternity care? And I still don't think we've quite got it right. Then the question is, are we adopting the right approach to it? Again, and this comes back to compassion. Are we adopting the right compassionate system? There's loads of great safety thinking out there in healthcare. We know that trying to adopt a safety one approach, which is learning from when things go wrong, doesn't necessarily lead to better outcomes. We know that if you adopt a safety two approach, which is actually learning and repeating when things go right, is actually the way forward. Yet still we have this safety one approach and this kind of constantly trying to just close every little loophole. And then we talk a lot at the moment about being trauma informed and this desire, again, within the system and for our women and service users who are using our system are asking us, and quite rightly, to be trauma informed. So if you've had a previous traumatic birth, then actually they want people to understand that. They want people to understand that they're going into their second birth frightened, that will be influencing their decision making. They want, if women have had, for example, previous sexual assault, which is much more common than we recognise, again, recognising the impact of having intimate examinations, the impact of having birth on those women. And again, trying to recognise that we need time to understand that, to be trauma informed, to have that compassion in the system, which is definitely where we should be heading and what we should be doing and that kind of care that we should be providing. But the question is, what would the way in which we've described maternity services overall has been quite traumatic for the people working in those maternity services too, kind of to go through this kind of constant maelstrom, to have what's felt like an almost unrelenting attack, despite people working incredibly hard, I think has felt very traumatic. And we need to be trauma informed about the way we describe our maternity services too, recognising that we're still not always getting it right. So overall, we do need more compassion in the system at all levels, and that needs to come from the top, and it needs to come from the very top, from the very top of policy to be able to make this better. I don't know why that's moving forward. And then the other thing is that we need to make that space for that creativity too. So we've piled so many things on top of everything, and what we're not giving people is the time to lead, the time to think, the time to create, and the time to really truly make things better for their own population. Okay, so we've had a lot of themes, we've had a lot of reports, and we've had a lot of investigations, and we've got a lot more coming this year. So this year we will have the publication of the Amos inquiry. We will have the publication of the Ockenden review into Nottingham. We'll also have Thirlwall with Lucy Letby as well. But actually, we could lump it all together and we could see that actually these are probably the big themes that we need to be actually looking at. So we know that there are things around some long-standing cultural hierarchies that are actually working within medical teams. There are natural hierarchies, and sometimes that does lead to poor behaviours and abuse of power. You do need those hierarchies in those teams, but how do we ensure that people use it wisely, I suppose? We know that in maternity care, we are having increasingly large teams that we have to work really closely with each other, particularly when we're looking at how we deliver care in the intrapartum setting. And that, but actually those teams can sometimes be unfamiliar. We don't necessarily know each other. We've changed the way that we do medical training, so we don't have that firm-based system anymore that Andrew and I would have grown up with. And we need to think about that, and we need to address it. I think one of the big things that we've got at the moment in maternity care that we need to really address is this fear of failure. So it's like, what we want to be promoting is high standards, is high standard care that is delivered in a professional way. But we also need to understand that human beings are human beings and that we can all make mistakes, and that we need a system that allows for that. But the system should also be creating those safety nets to stop those mistakes actually turning into patient safety issues, and understanding those things that are really quite delicate. And I don't think we're getting it right. We need to think about the ways we create the right cultures for maternity care. So you need the right balance of supportiveness and functionality. So a highly functional culture will be one where everybody knows that these are the rules. Nobody's always have to turn up on time. I mean, turning up on time is good, but you have to. You can't ever show any weakness. You can't ever be wrong. Everybody has to be perfect. And people think those are safe environments, but they're not, because actually we're not creating the space for people to be able to be themselves, and that creates a fear of failure. And a fear of failure actually then makes people make the wrong decisions. Similarly, though, if you're too supportive and if you're like, oh, it's okay, understand, oh, it's okay, oh, it doesn't matter if you're late, it doesn't matter if oh, it's okay, bad things just happen, and people don't feel as though there's a system that supports them, that's also not a safe culture. And getting that balance right is really important. We also know that we need to create systems that have spaces. Sorry, I don't know why it's moving forward. We also need to create the right spaces for psychological safety, and we talk about psychological safety all the time. Again, these are terms that we've got much better at talking about, but the question is, are we actually truly addressing them, and what are the things that we can do? And that we just need to allow this space for humanity, vulnerability, and connection overall. But of course, one of the most consistent themes that we are getting from, again, these reports and that we do need to listen to as a maternity system, is this thing about listening to women. So the question is, how can we get this right? How can we get it right that we are actually truly listening to women, and why is it we're not listening to women? So one question is it structural misogyny that's causing that? So this is an NIHR report that looked to see, that says that actually women across healthcare overall don't feel listened to. Is there something about the way that we've always described women's symptoms, that will minimize symptoms, or that we address, for example, pregnancy symptoms, that has meant that women don't feel listened to? And I think there possibly is a bit of that. I think that if we look, for example, at hyperemesis, which is a terrible thing, hyperemesis, just that we had always described it, certainly when I was first in training, that you could only have hyperemesis if you were vomiting so much that you had significant amounts of ketones in your urine, and you were really dehydrated and losing weight. I mean, that's quite extreme, isn't it? But that's really, at that point, we took you seriously. And the poor women in between, or the women who weren't vomiting, who were just horrifically nauseated, have got awful fatigue, feel dreadful. These are the kind of things that we would definitely tackle for people with cancer, but yet, because pregnancy is a physiological state, we haven't. And I think those things like that are gradually moving. And I think there is some of that. But there must be something around how we are able to connect with women, and whether or not we've got the time and the space to truly listen to women and make them feel heard, and why it is we're not doing that. And the question then is, how do we make it better? So how do we empower our staff to do that, to have the ability to do that? And so then we need to think about whether or not we need a new approach, basically. So this is what I'm thinking about all the time. Are we actually getting it right with our current approach in national maternity care? So if we have a look at all those reports, there are currently nationally over 700 recommendations to improve maternity care. I went into a trust recently, because that's one of the things I do, is I go around a lot of trusts. And this particular trust doesn't have very high birth rate. has about 2,000 births a year, and this trust had 60 different improvement work streams. I mean, that's insane, isn't it? How do you prioritize if you've got six? You can't prioritize. What is the priority, and how are you actually achieving any of those? I think we are mistaking ourselves in thinking that in measuring things we're improving. Let's measure more. Let's and there's more command and control in that measurement as well, and that somehow by measuring we're somehow going to force more improvements. I don't think that necessarily is true. We need to think about the role of regulators and how regulators work together. We need to make sure that we're thinking about outcomes rather than processes. And again, I think we've made ourselves very, very busy in maternity care, doing a lot of audits that look at our process measures and aren't necessarily looking at our outcomes. And then are we really addressing those poor behaviours and also unsafe cultures that exist? Are we getting it right? And actually, are we looking at a loss of compassion in the system overall? And if we reintroduce compassion from the top that really understands that this is what people are grappling with on the shop floor day in, day out, actually, is that the thing that is actually going to make things better? And my argument is that I think it would. So how do we define compassion? So, because again, we kind of bandy this term around quite a lot. But it's different to empathy. So empathy is kind of having that kind of shared experience, feeling somebody else's pain, isn't it? But compassion is that next step, and compassion is the thing that kind of helps to alleviate you from burnout if you are somebody who's very empathetic. So it's described as a sensitivity to suffering in self and others with a commitment to try and alleviate it and prevent it. So it's linked to, but it's different to empathy. I had a quick look to see how genetic it was. The reason I think that actually is because I've got 3 children who all have very different levels of empathy. Really interesting. Nature versus nurture, same environment, very, very different empathetically. And it's very interesting, and we know that there's huge amounts of things that are very much kind of in our genetic. But so we think there is a genetic component, although nurture environment definitely affects it. And we certainly see that in healthcare when we start seeing the impact of the environment on us. And why is it so important? So, I mean, there is so much out there on this. There's so much out there on the impact of compassionate leadership in particular. So Michael West is the expert in this. He's written some great books. You can go on YouTube, you can watch his talks, etc. as well. But there is just really clear evidence that compassionate leadership results in more engaged and motivated staff. You have higher rates of well-being, and that in turn impacts on quality care. And I think I very much felt this, for the first time, I think after, going back to after I had my first baby, when I first went to being, I was a part-time doctor, not never that part-time, 36 hours a week or something, but it's all relative, isn't it? But I didn't work on Mondays and Tuesdays, and I would come in on a Wednesday fresh, having had a lovely day the day before, and everybody else would be just fed up already, and I'd be like, it's great, hello everybody, how are you all, nice to see you. And actually I felt that that balance in my life actually probably at the time made me a better doctor, probably particularly where I was at the time, which is several years of working incredibly hard and probably on the verge of burnout. And we need to recognise that, and we need to recognise and support people through that. We also know that if working in teams with clear goals and good team leadership have lower levels of stress. And again, we're not creating environments where everybody has that same shared vision. If you've got 700 recommendations and 60 work streams, how can you have the same shared goal? How can you make sure you're all working together as one team? And that we know that actually improves things for organisations. And that in NHS trusts where staff report the absence of leadership, that's where staff report higher levels of work overload, less influence, and they have poorer outcomes. Yet we are also in an environment where the finances are getting tighter and tighter and tighter in healthcare. So I work at NHS England where I see people saying we want people to do more and more and more, but there's no more money. And then I work within a trust where I really know there's no more money because we're being asked to do more with less all the time, and how that can gradually and generally erode goodwill, despite the fact, and I work with absolutely brilliant and amazing colleagues who work really hard and really care. And then obviously that then means that, when you're being treated compassionately yourself, then of course it's easier to treat other people with compassion. If you've just come from somebody being lovely to you, and you feel as though you've got time to spend with somebody, then actually, of course, it's much easier to pay that forward. Of course, that's how it works. Of course, actually, if you go to work and somebody shouts at you, or you couldn't park the car because they've changed the car parking thing. Car parking is a big thing that comes up everywhere, by the way. Not that I can solve that nationally. Car parking, computer, IT, etc., etc. But these are the things that make people feel valued at work. And if we're decreasing people's value, then it's much harder for them to feel that compassion. And when you haven't got that compassion, how do you then try and really engage with somebody in a very short appointment in front of you? So we know all of this, but the question is, are we really truly delivering that within our services? And the difficulty is that for the leaders, it's very hard for them to be leading like that because they're being asked to do so many other things that's so distracting at the same time. And then this is the other context we're working in. So one of the things that we keep being told all the time at the moment is that in the UK, our birth rate is going down, and that we've got more doctors and midwives than ever. But actually, we have significantly changed the way we deliver maternity care in the UK. So our induction of labour rates have gone up substantially. And behind that figure isn't just that's the induction of labour rates that we're actually doing. There's also all these women that we're saying that recommend having an induction. So that, and it's all done on this kind of global scale to try and improve safety. But I think what we're actually seeing is actually what probably is doing is making things more unsafe. And there's probably a national conversation we need to have around this. You can see as well that our operative birth has gone up, our assisted vaginal birth has gone down, and therefore unassisted vaginal birth has dropped over the course of over recent years as well. That also means that the estates that we're working in aren't working for our current model of care. Better Births that came out in 2015-16 was talking about having midwifery models of care, women birthing at home in these lovely birth centres, etc. So all these beautiful estates have been built, and now we have very few women going through those centres. So, but what we're having a lot of women going through are our theatres, and that's causing bottlenecks in the system. But this is also the other context we're working in. So I think that we also need to recognise that society has changed in the last 5 to 6 years because we went through a pandemic, and I don't think we recognise it or talk about it enough. And people's attitudes to life, I think, has changed post-pandemic. People's personal lives got very significantly affected. And I think certainly some of the women that we are looking after now who birthed in the pandemic had very traumatic births when people couldn't smile. I remember I used to caseload women in a particular clinic, and sometimes I would deliver them by cesarean, and there were women I'd looked after all through their pregnancy, and very occasionally just at the end of the cesarean they'd take their mask off, and I'd only ever seen them with masks on. And you've imagined somebody's face different. It was a really difficult time, and that smiling at somebody when they've had a baby is so important, and we lost that, and that ability to touch somebody and say congratulations, and that went, and I think it was very traumatic. And I think we're seeing the effects of that still coming through. I think we've got bigger teams and less chance to connect with each other. We've got governance, as I've said, focused on adherence to guidelines rather than understanding patient and human factors, and we need to tackle that. And we've got this real tension between safety and personalisation. And so that basically means that we need to address where we are at the moment. And I know the RCOG is talking about this all the time, but we need to marry up what we are recognising and talking about with actual change and action, and we somehow need people to see this, because I think one of the things that we're at danger of is getting into this place of tolerated incivility. Because actually, compassion and kindness is saying, well, I recognise that somebody is going to be a bit off with me today because they've had a really tough time. They've been on call overnight. That my poor colleague has had a really tough case last week, etc. But then how do we get to the point where we're actually saying, actually, that's becoming a normal pattern of behaviour? That's the normal pattern of behaviour for this unit, for that person. And how do we make sure that we're actually addressing that? And I'll come to that in a minute. Because this is what we are definitely seeing in all of this. So this is the latest workforce report that the RCOG did, that came out of their workforce census. So we know that unless we start addressing these things at the very root of them, then we're not going to get better. So we need to get this balance right. And compassionate leadership is about creating the right environment and creating the right systems for people, but it's also calling out those poor behaviours too. And there is that balance that we need to strike. What we definitely need to step away from, though, is this kind of tokenistic well-being that we seem to have kind of got quite into. I know this was a terrible thing that kind of went viral a few years ago, where an NHS trust sent everybody a tea bag. But literally they did send somebody a tea bag in the post. I can also remember, being a relatively junior doctor and needing to charge my phone and somebody telling me off because I was using NHS electricity when my phone needed to be charged. Or for a little while, everybody saying that, there were signs up saying that, people couldn't use the kettle for tea and coffee and that kind of thing. So there is this balance, isn't there? And I think that what we've had is that the term resilience has become, again, a very toxic term. We need to talk about the fact that we need resilient systems, and resilient systems are a different thing. And actually, as people working in maternity care, you need to have resilience. But resilience isn't about making you culpable for bad things happening. Resilience is about having a system that supports you and having that network and make sure that you feel supported in that space. So how do we do it? So rather than kind of just giving people some tea bags or telling people that, that there's a support service for helpline if they're feeling a bit glum, how do we actually make a compassionate maternity system for everybody working within it? So first of all, I think we just need to get the basics right. Let's just get the basics right. Let's just make it easy to do the right thing. Let's stop piling things on top of each other and making it really complicated. Let's just do it right. But also getting the basics right as somebody who works for the NHS also means paying people properly on time, making sure that, those simple things that are just done well. And again, that needs the right infrastructure for it. We need to make sure that we're allocating the appropriate time for appointments, for leadership, for education. And again, we've seen that we have our acuity rates have gone up. Women want different things from doctors, I think, overall in the system. But we've been really slow to keep up with that. So again, if you are in an overbooked antenatal clinic with appointment times that really need half an hour, but you've only got 15 minutes, then it is so hard to maintain that compassion as you get to 7 o'clock and you're late for the nursery pickup again, or you've missed your gym class, or whatever it is that actually the important things for you, because you're working in a system that's not actually supporting you to do the right thing. So we need to do that, and we need to be fighting for the right systems to do that as well. We need to give our staff autonomy and freedom to actually deliver that personalised care and to have that connection with human beings and be able to have that connection with somebody who says, this is what I want, and to feel safe enough to say, yes, that's okay, I will support you, that I will listen to you. I say that as somebody that's spent a lot of my time looking after women and supporting women who want care outside normal guidance and really truly understanding what they really want. I think sometimes can be quite scary for people, but actually it's about supporting women to do the right thing for them. But you need that freedom and that autonomy and that ability to be able to do it yourself, which I think I can do as a senior person. But the question is, how can I empower my juniors to do that as well? We really need to listen to staff at all levels, and staff need to feel heard. And I hope that the kind of calls for evidence that will come through the next few inquiries will do that. Let's see. We need to get brave, and we need to think about de-implementation, because we have all of this safety clutter as well. So we have all of these things that we've put in there that we think are improving, but actually they're just clutter and we need to get rid of them. I know, Andrew, you mentioned continuity of carer. I think, again, continuity of carer has become one of those quite toxic terms. But again, I think that actually if we deliver true continuity for our women, it makes a real difference for them. So again, thinking about innovative ways in which we can provide that continuity. And I know certainly one of the greatest things I love as a consultant is being able to provide that. We need to adopt that safety thinking. And then we also need to be considering maternity care as part of the wider health landscape, not in isolation. And this constant kind of thing around we are failing because we are because we have inequities, etc. We're not considering the social determinants of health, and as obstetricians we only look after women for a really short period of time. I think is really damaging, and we need to really consider that too. And then just this thing about compassionate cultures, really. So we need to think about normalising joy at work, and that it's okay. It's okay to enjoy work. Actually, I think it's and we can enjoy that. And actually, looking at somebody's face when they meet their baby for the first time, is a really special thing and is quite amazing. And I think we've forgotten that, and I think we need to bring that back. We need to be able to have respectful professional behaviours and challenge poor behaviours and champion women's voices and speak out when things aren't right as well. And I think just focusing on the one thing I really would change in maternity care, which is actually being trauma informed. And you can only see the word there at the bottom actually, but this thing failures. So one of the things I would do is take out the word failure from maternity care. This horrible thing, these 14 trusts investigated over failures when actually many of them were selected because they'd improved. But yet that wasn't in the press, and the damage that's been caused and this kind of constant fail. Women don't like, understandably, being told that they have failed to progress or etc. And actually, can we take that out, and can we truly be trauma informed? Can we focus a bit on the positive change? And I think it's a really difficult debate that we've had, where I think in saying that actually maternity care has improved or has changed, that is somehow disrespectful for people who have had poor experiences, and there are those people who have had terrible bereavements or things that haven't gone right. But actually we can do both. We can both be trauma informed and look after those people and still be talking about those positive things. And I think if we look to the future, I think we have a really talented workforce coming through. So if I look back on my days, which were, the same as Adam Kay's back in the noughties, we had quite, actually, even as trainees towards each other, people were quite harsh. It was quite a harsh environment. I look at the trainees that we have coming through. I think we've had a real focus on bringing really compassionate people through. They are lovely. They are lovely people who are really nice to each other, who are really nice to work with. We need to get rid of, even when I was training, everybody was like, in my day, it was this, that, or the other. We need to, again, let's get rid of that. Let's look and focus on that talented workforce and keep nurturing them and keep supporting them to be those kind, compassionate people that they are. We need to celebrate the successes. We need to celebrate the fact we've got much better and more collaborative working across the MDT. And we need to celebrate the fact that we have got closer working with service users as well. And then just two more very quick slides is really just what we can think about as individuals to be compassionate and how we as individuals can do this. So I think the first thing that we can do actually, and as doctors and midwives and healthcare professionals, many of us are perfectionists and many of us are very type A and many of us lack self-compassion. And self-compassion isn't just about being kind to ourselves and things gone wrong. Self-compassion is sometimes putting ourselves first. It's very, very hard though, isn't it? We are not designed to, our systems aren't designed to put ourselves first. When we're working, we can't put ourselves first. We're designed to override our physiological needs, but sometimes we also do need, as human beings, to be able to look after ourselves. And that includes things like respecting each other's boundaries, which I think is really important, and everybody has slightly different boundaries. We need to reflect on our own behaviours and learn to change and say sorry sometimes as well, sometimes when we've done things wrong, and promote that balance and allow people to be those human beings and to have those lives, because that's the only way we're going to maintain the workforce going forward, particularly with a newer generation coming through. That also then involves diversity of thinking from other teams. Again, that is a compassionate thing to do, to have that diversity of thinking and to learn from each other, and to be brave and be willing to hear uncomfortable things. And then this is just the last slide, which is basically about us all being part of the solution. Because what a lot of the things I've described, again, we can say, well, actually, somebody else is going to do that. The RCOG is going to do that. NHS is going to do that, et cetera, et cetera. But actually, how can we as individuals be part of that solution when we go to work? And because actually, what it boils down to is, it is us with that woman, with that family, with that father, and actually those connections that we create change lives, and they change lives for the worse or better, and we can do that. And I think we see that all the time at work. So it is about that creation of those positive workplace environments, not just the leader, flattening hierarchies, stopping the infantilization that we have in the medical training model, finding good role models, acting with integrity. And I think that connection as well, and just like truly connecting with people, just going to work and asking somebody truly how they are. Did you have a nice weekend? How was your day? People have said that we can't do that because we don't have a firm system anymore. And I would really challenge that, and I really enjoy, one of my favourite things to do is the cesarean list, because I get to have lovely conversations with ST1s and 2s usually, and find out what things are like for them. And it's brilliant. Connect with vulnerability, and then this other thing, which I think the most important thing that we can do, is asking ourselves constantly, how do we make people feel? We've got this focus on non-technical skills, but how we make people feel is so important. And then saying thank you as well. So saying thank you to our colleagues, saying thank you to each other can be such a powerful thing. And I'm going to stop there. Have a discussion. Thank you.
Fantastic. Thank you so much, Susie. What a sort of tour de force around the whole complexity of maternity care as it is. Questions in the room, thoughts, things you'd like to talk about. I'm just aware there's 50 people online, so whatever you say, we're just going to repeat because they won't hear it online.
I think you're saying obstetricians aren't, as individuals, compassionate enough. How can you teach them as individuals, not through the system, but as individuals, to be more compassionate? How do you go about that?
Well,
Can I just, so the question is, how can we teach obstetricians to be more compassionate if that's a problem?
So what I think is, I think that the attributes that we used to be expected to have was that we weren't compassionate. That kind of harshness was part and parcel of who we were. I think that actually there has been a decision to change that actually in training. And I think actually certainly the trainees that I'm seeing coming through are hugely compassionate. I watched one of my ST3s the other day, the way that she was just being so lovely with a family. So it's just, I think we are, I think we need to be promoting it as a positive thing. There are talks about going on compassion training. Yeah. The jury is out. I think that is something that is out there. Let's see. That's certainly things that people are talking about.
Well, if compassion speaks to empathy, you could get at that through some sort of balanced group type training. Balance taught GPs to discover their empathy, really. Maybe you can do that with obstetricians. Might be a tougher job, I don't know.
Yeah, I think that's certainly been tried. I think again, it's been tried, but the failure always in obs and gynae is the workload basically. But I think these are one we also need to keep talking about it. So yeah.
One of the questions online relates particularly to that, which is talking about one of the symptoms of burnout is loss of empathy.
Yeah.
So there's a sort of vicious circle going on here, whereby the more burnt out people get, the more depersonalization there is, which then leads to further criticism, which leads to further burnout, and it's spiraling down.
So it has to be an all systems approach. I think. I don't think just putting. I think that there are things that we can do from a training perspective, but I also think that creating an environment where it's normalized and where people feel as though people are being compassionate towards them, I think is also the key.
One of the problems that you alluded to was the multitude of recommendations that we've got. So, okay, we've got the widely quoted 700 or so recommendations from the reviews, but actually we also have guidelines from RCOG, from NICE, our local guidelines. We've got CNST reports, we've got CQC, we've got the data coming through, all of which we need to respond to. We've got legal considerations, we've got complaints coming in, and there is this huge amount of top-down pressure, and all of which need to be responded to. And yet these organizations often don't talk to each other. And so I can completely understand how there's 60 different streams going on in an organization, because each of them needs their time, and yet we're running out of money. People aren't prepared to pay taxes, and therefore the amount of money for healthcare is reducing, and yet we're spending enormous amounts of money on just responding to all these issues. How can we streamline that? How can we try and bring it together? Because guidelines surely are a good thing, but when there's so many, it just gets ridiculous, doesn't it?
Well, I agree, and I think that's one of the reasons we probably need to look at. I think there's probably a few ways we need to do that. I really think we need to have a really good look at the way we are doing maternity governance at the moment. I think that we were kind of probably getting it right for a few years, and as I said, I think maternity governance has become, through some of the kind of regulatory requirements, very tick boxy, and not really getting under the heart of actually what is truly going on, what's our true culture. And as I said, it's all about adherence to those guidelines, and that's not really what patient safety is. And I think we need to be getting our governance right, and I think that's definitely something that I want to be focused on this year. I've got quite a big asked to do that, and then yes, absolutely. And then the other thing is whether or not across all of those different organizations we can all come together and say, actually, can we just be brave and strip things out and just make things more simple, because we're just piling too many things in. And I think that that's certainly been a lot of the, with the AMOS inquiry, I think there's been a lot of noise of people saying, please, let's not have another report with another however many recommendations. We will see what comes of it.
Okay. Other questions? Yeah, Derek.
Comment. If you don't look after the staff, don't be surprised if the staff aren't very happy, and that reflects in their work. I mean, I'm quite shocked. We've got a son and a daughter-in-law in surgery. We know loads of people in surgery, general practice, and so on. And practically every single one of them is looking forward to the day they can get out of the health service. That's quite an achievement, to turn highly motivated people off as they do. When I observe what's going on in the health service, I'm just shocked. Over my career, well, when we were housemen, we were housemen. We weren't letters and numbers. You talked about ST1 and ST2. I talked about registrars. That is depersonalizing, in my view. Not your fault, the previous chief medical officer's fault. But all of this stuff, the fact that you can't get food in a hospital at night, there's a whole string of these things which lead to people not being happy. If you're not happy in your work, you are not likely to be as receptive and compassionate as people as you would otherwise be. And I think it all kind of gets right back to how employees are treated. And it's not just doctors, it's nurses, midwives, across the piece. The health service is a rotten employer. And a lot of things come from that.
So let me just summarize that for those online. Talking about the difficulties of working conditions for many of the staff, and saying that we heard examples of problems, but how actually, if you don't look after your staff, how can you expect them to deliver compassionate care? I don't know if you wanted to respond.
No, I mean, I agree with that. I quite often say, I love my job, but I hate working for the NHS for exactly that. You know, you just, as I said, just things like getting your pay right. My husband's pay is consistently the same. My pay seems to change every month. You know, it's just those simple things. And I think that what we've relied on is a huge amount of the fact that actually doctors, midwives, nurses, you know, people are, you know, we actually are a very, you know, kind, compassionate group of people that generally go into healthcare, but we're relying very heavily on their goodwill. And I think that goodwill is getting eroded. So, and I think it's what we have to keep addressing it and keep speaking out for it.
Got an interesting question online about how we deal with communication with people who are neurodivergent. So neurodivergence clearly requires special skill to deal with people in such a stressful situation. But then it also then comes on to those people using interpreters, which then becomes very difficult. Language barriers are hugely complex. How can we try and deal with all that? Because we have enough difficulty dealing with people without those special requirements. That trying to add it in when we've got so little, so the staff seem not to have enough time to do that.
Oh, I think certainly there's increasing recognition of the importance of communicating with neurodivergent people, whether or not that's staff or patients alike, etc. And I think that, you know, the RCOG are producing a best practice guide on it at the moment. I think, you know, certainly the trainees committee have done a lot of work around it. So we've certainly seen it from the point of view of, you know, interacting and making sure that we've got that equity for all staff groups. And I think that's really important. And again, similarly, I think increasingly there are services that are being set up to support women who are neurodivergent, and I think that's really important because, again, it's just, you know, there are lots of different ways in which care can be inequitable, and I think we talk about many of them, but that's definitely one of them. Again, things like interpreters. You know, if you need to use an interpreting service, then you actually need a longer appointment time, and we need to be, you know, for services that have significant numbers of women for whom English is not their first language. The only way you will get equitable care is by that trust essentially supporting and funding longer appointments so that you can get it right.
Yeah. Okay. Other questions, comments? Yes.
I'm a medical student, and I was just wondering, we hear suggestions of people's empathy and compassion are at their highest at the very start of medical training, and then there's a downtrend from there on out. Do you have any suggestions towards medical students specifically, or those involved in medical education, as to how that could be maintained?
I think it's a really...
repeat the question for those.
Oh yeah, so it's a question from a medical student about the fact that apparently so compassion and empathy is its highest at the beginning, and then it gradually declines. I mean, it'd be interesting to see the studies on it. What I always think, certainly in my own experience in obs and gynae, is that it starts high, and then I definitely felt it. I definitely experienced that dip. I think particularly when I was about like kind of a couple of years into being a registrar, you've got, you know, that kind of this balance of not quite having enough experience relative to the amount of pressure and responsibility you had, and it was a kind of bit of a perfect storm. But I think that then I think that most people come out of it, and I suppose it's probably part of the kind of natural part of the training process, but because actually if you have so much empathy that you are experience, you know, that can experience burnout actually if you take on everything that you see, etc. So there is a balance, but I suppose it's creating and turning that empathy and that compassion into that positive good, and so making sure that you're retaining it, so that actually what you truly want to do when you go to work is have that communication and really truly kind of make sure that you've got that connection with someone. So I definitely feel that. So when I go to work and I sit in front of a woman or a family, the most important thing to me is that I create that connection with them, and that I feel that when they've walked out of the room, I feel that they have felt safe, that they have felt listened to, and that is honestly the most important thing. And so it's maintaining that as being your high priority, I think, is probably the key thing.
Okay. We have another question online asking about professional midwifery advocates, which you'll know is a system within midwifery where midwives provide, there's a group of senior midwives who provide emotional support, debriefs, and asking whether there's something we can do similar for the medical profession. so as to provide that support, because the teams where you used to receive that largely have gone. The team culture, and it's goes all the way back to working time directive and such like. We no longer have these firms where you would get mutual support. They've created that for midwifery. Is there something we can do similar for the doctors?
So I think that's been talked about for a long time. I know actually, so Ali Wright, who's just become president of the RCOG, she set up the Supporting Our Doctors Network, and I remember being at a meeting talking with Ali, talking about it and saying we should have a similar thing for doctors. Like all things, it would rely on funding. That's the problem. So so there was definitely a conversation about it, but then it was the question then was, well, actually, are we just going to pile more things on busy people's workloads, and there isn't the systemic funding to support it. I work nationally with the lead of the PMA system, and they are they're woefully underfunded, but they are funded posts. I also fully appreciate that the impact that they can have. I personally think our PMAs within our clinical environment make a really positive difference. I think the training that they've had, and the fact that actually sometimes people can reach out to you. I was having a really difficult day the other day with just an overbooked clinic. I didn't have the right staffing levels for it. And one of the PMAs came past and just gave me a cup of tea, and that actually made quite a big difference. But also those connections. So I don't disagree. I think what we have is, in some environments, I think you have some consultants in some roles, or sometimes senior SAS leads, etc. as well, who do provide that nurturing and support. And again, it's about recognizing the impact of that. And sometimes they're the labour ward lead, sometimes they're the college tutor, etc. But these things take funding, don't they? Unfortunately.
Well, indeed. We're setting up at the moment at Liverpool Women's Hospital a peer support network, which is set by a group of us, the staff support team, which includes psychologists. But in that, an interesting twist on it is that we're not asking people to volunteer. We're asking all the doctors, who would you like to be on the peer support network? And it's actually the usual. They're the same people I would have suggested have been chosen. And then when you go to them and say, actually your colleagues have asked you to be, have suggested you as one of the peer support mentors. But somebody who's prepared to say, okay, I'm if you have problems, come and speak to me, and provide that support. Because sometimes those of us who put ourselves forward aren't necessarily the people that people would come to. So yeah, it's an interesting take that we've had on it at the Women's Hospital.
Yeah, I think that we need to maintain these kind of things at the top of the agenda. As I said, the problem is that if we're so busy with all the other things that we're doing, and we're so distracted by spreadsheets, etc., the question is, how do we make sure actually we say that in order to, if we're really trying to make maternity care safer and better, this is actually the priority. So I suppose there is going to be something in all of this about that prioritization piece, isn't there? And saying, exactly as we said, what we need to make sure is that we have got a system where the staff feel looked after and supported, and that being compassionate is the attribute that we are recognizing as really high in them, and that we want them to maintain that. But in order to do that, we need to create the right systems around them. So there's
a very good chat going on online, so I'm struggling to keep up with it at the same time as asking. But just an interesting comment that somebody says, speaking as a PMA, as a professional midwifery advocate, obstetricians are more than welcome to come to us too. And I'm sure that would be the case for the obstetricians.
Absolutely, yeah, and certainly when whenever we have a case with a poor outcome, etc., certainly our PMAs absolutely say that, and it's that's, they're not just there for the midwives too.
Well, we have a team of psychologists who are 3.5 full-time equivalent psychologists, purely to look at the staff. Nothing to do with they're not patient facing at all. They're purely staff facing. And actually the effect of those, because there's a large number of people off sick, and actually even if you just bring back 1 or 2 of those people who are on sick, then it pays for itself. So the business case actually comes from the amount of money that is being spent with people off sick. So just one last question that somebody's got. and the person says, for those who are not in formal leadership roles, what is one small but impactful action that you have seen to shift culture and flatten hierarchies? So maybe that's a good question to end with, because I'm aware we're after our 7 o'clock finish. So what would you say?
Well, people who know me aren't going to be surprised that I think that firstly, just actually asking people how they are and actually having that kind of interest in people and getting to know people, I think it's really important. Just truly, asking somebody who they are, where they've come from, making them feel actually that you respect them as a human being. But the other thing and then actually that kind of humility, I think is really key. So actually being able to say, I don't know what the answer is. I can be wrong. If I think about some of the best colleagues that I've ever worked with, one colleague in particular who is just probably who's just a phenomenal obstetrician and everybody loves him. He is absolutely brilliant at that, and just being able to be wrong, being able to say, I don't know, let's look at it together, I think can be such good role modeling, because that really flattens the hierarchy. That makes everybody say, yes, that's basically saying, I don't have all the answers, let me ask you as well, and everybody can feel part of that team.
And it's interesting that that's part of the same culture which has reduced hours and which affects work-life balance, actually is bringing through more and more people who are able to do that, who are the sort of compassionate, communicative type, the more friendly, family-orientated type. And that's quite a culture shift, but is producing exactly that sort of change that we're seeing. So, Susie, thank you so much. We've gone over time, but I wanted to get through a number of these questions. I wish we could have more, but thank you so much for coming. It's been a fantastic overview, and to get the insights, sort of, I guess, from the heart of NHS England as to how you, as such an influential person on the circuit, is thinking is fantastic, I hope that everybody online enjoyed it as well. We do have a small token of our appreciation here, which, if my computer doesn't fall over, which is a little medal that we give to people who have spoken at LMI. So thank you so much for coming. The next lecture in the series is going to be given by Benjamin Black. Now, Benjamin Black is a fascinating, he's also one of your London colleagues, but majors on work with MSF. So he's the maternity advisor for Médecins Sans Frontières, and people may have read his book, Belly Woman, which is all about his experience providing care for people with Ebola in Sierra Leone some years back, which is a very good read if anyone gets a chance to. But that's going to be in 2 weeks' time on Thursday the 5th at the same time. There are some snacks for those, sorry, online, I can't give you snacks, but for those who are here, there are some snacks next door. So come through and I'm sure you'll be happy to take some more questions and answers and discussion next door. But thank you so much for coming. Thank you for those attending online, and we'll see you in a couple of weeks' time.
Thank you.